request of the exam goings who are appearing for their practicals within another 2 weeks, I have made this comorbidities topic on COPD and IST more or less in a combination of OSCE questions as well as case presentation questions. So I hope it will be useful to the students. Welcome, Dr. Vasanthi.
Good evening, madam.
Nice
Thank
to
you,
see
sir.
you. Very, very happy to see you.
Thank you, sir.
Thank you. So without wasting time, let me go on to share the screen with you. And hope all of you are able to see the screen.
Yes, sir.
Yes, okay. So we'll start with the pathophysiology of COPD. So it's going to be a sort of interactive session. So the first question that comes up in the exam may be, how do you define COPD? Can any one of you answer that question? Definition of COPD?
So it is a chronic and a persistent obstruction to airflow because of chronic inflammation, which is due to a noxious stimuli or a noxious gas.
Okay. Is it reversible or irreversible?
It is irreversible.
That is the most important point. So COPD is a progressive, instead of saying chronic, you can say progressive airflow limitation that is not reversible. So simple one-line answer for that question is, COPD is a progressive airflow limitation that is not reversible. Will bronchial asthma come into this category?
No, sir. It has bronchodilator reversibilities.
Reversibility is there. That is why only two conditions are included in that. What are the two conditions?
Chronic bronchitis and emphysema.
Fantastic. Very good. So anything, but can chronic asthma become COPD later on? The person suffers from chronic asthma for a number of years. Will the airflow reversal limitation will get continued, become non-reversible? It can become also. Okay. So there is, even though it is not included in that, the persistent prolonged asthmatic patient can become a COPD patient also. Okay.
Okay, sir.
What changes in the pulmonary architecture lead to this condition? What are the changes that take place in the pulmonary system? All of you know that the pulmonary system consists of the tracheobronchial tree going up to the alveoli, isn't it?
Yes, sir.
So in which part of this tracheobronchial tree the changes happen?
Sir, both larger and the smaller airways and lung parenchyma.
Both larger and smaller. You mean then the trachea and the major bronchi also will be involved?
Respiratory bronchioles only will be involved.
Pathologic loss of elasticity or recoil first within the lung parenchyma. That is number one. Loss of rigidity of bronchial wall and collapse during expiration, and increase in velocity of airflow in narrowed bronchiole, causing a decrease in pressure and collapse, and active bronchospasm and obstruction and secretions, destruction of lung parenchyma, enlargement of the air sacs, and emphysema. So these are all the changes which lead to that. So mostly it will be the medium sized and the terminal portion of the lung which will be affected. Okay, it is not the more stronger cartilaginous upper portions like your major trachea, bronchial divisions. All those structures are not very much affected, but it is the medium sized and the smaller airway and up to the alveolus also it will be affected. So if you see this picture, it is the bronchiole which is coming here, and you can see this is the normal lung with a normal adjacent alveoli. But when it becomes affected with COPD, you can see it becomes the walls of the alveoli become destroyed, and the type 1 pneumocytes which are there are not properly replaced by the type 2 pneumocytes, so they become weaker and start permanently stretched out. That is the condition, we call it as emphysematous changes. So this picture will tell you more about the respiratory bronchial and alveolar duct and acinar emphysema and secondary acinar emphysema. So the most terminal portions are very much affected in the pathophysiology. Now, what is Weibel's lung model?
Weibel's tracheobronchial tree, which consists of 21 generation
21
of
or 23?
23, sir.
23 divisions. Okay, so Weibel was a person who constructed this. So he went on to generation. He called it as a generation. So 23 generations are classified, out of which tracheas is the first generation. Then it goes on dividing into the bronchi, bronchioles, and ultimately to the alveolar sacs. And if you see the diameter, the size goes on decreasing and goes up to 0.04. And length also goes on decreasing, but the number goes on increasing because they divide. What is the division called? Is there any special name to say describe how they divide into each? For example, the clue is first the trachea is a single tube. It divides into right and left main bronchus. So further it will go into the lobar bronchus, and each lobar bronchus, how they will divide. Any idea about it?
Segmental bronchi.
See, if you see the number, 1 becomes 2, 2 becomes 4, 4 becomes 8, 8 becomes 16, 32, like that. So what do you call that sort of division? It is called dichomatous division. Okay. So it is called the dichomatous division to go on to produce 8 to the multiplied by the 10 to the power of 4. That many number of alveolar sacs are there. Okay?
Yes,
And the tracheobronchial tree, sometimes they may ask you all the divisions in the examination. The examiners are fond of asking how many bronchopulmonary segments are there. So if you see the upper lobe, the right side, it has got 3 segments, and in the middle lobe it has got 2 segments, and in the lower lobe it has got 5 segments. So 3, 2 plus 5, totally 10 segments on the right side. And some books say left side it will be only 9, but there also in the lingula they are giving equal number of divisions like the middle lobe. So there also you have the upper lobe having 3 divisions, the lingular lobe having 2, and the lower lobe having 5. What is the importance of knowing about this bronchopulmonary segments, which we have seen in our basics of respiratory system class? What is the importance of knowing about these bronchopulmonary segments? Why the examiners are
postural drainage and the positional.
very good. One is to know how to drain them. If each segment is affected, you must know how to clear them of their secretions by putting the patient in various postures. That is number 1. Very good. Any other reason?
Surgical resection.
Surgical resection of these segments. So you should be able to find out whether patient will be able to have a normal life if you resect how many segments of this affected diseased segments can be resected safely for a person to lead a normal life post surgery. Okay, so these are the 2 reasons why we should have an idea about the bronchopulmonary segment. One is for drainage, another is for resection of the diseased segments. Okay. Now, what are the risk factors for development of COPD, or what are the causative factors which lead to the development of COPD?
Smoking.
Smoking, very good. Cigarette smoking, excellent. First and foremost, very, very common cause. Then
Firewood cooking, sir.
firewood cooking. So you mean some pollution, okay? So
Yes.
repeated respiratory infections, occupational exposure to dust coal, gold mining, and textile industry, and genetic factors like alpha 1 antitrypsin deficiency. So these are some of the common triggering factors for the development of COPD. Smoking, recurrent infection, pollution in the air, and congenital deficiency of the alpha 1 antitrypsin. Now, what are the types of chronic obstructive pulmonary diseases you know? How is it classified? Already you have said it is chronic bronchitis and emphysema. These are the two categories which are caused. Now, what is the difference in the appearance of the patient with emphysema and chronic bronchitis which helps in diagnosis? How do these patients look? How is it the description given?
Blue bloaters and pink puffers.
Fantastic. Blue bloaters and pink puffers. Who is blue bloater and who is pink puffer?
Emphysema patients are pink puffers.
Very good. Chronic bronchitis patients are blue bloaters because they are always little bit cyanosed. They are in hypoxemia. Whereas the emphysematous patients are never in hypoxemia, but they always have a labored breathing. They have a pursed lip breathing and they find it very difficult to exhale. Why is that? They don't have desaturation, but they are finding it more difficult when they develop emphysema to breathe. Whereas chronic bronchitis patients, they are desaturating, they are having a constant cyanotic look, but they are not having a labored breathing. Why?
Because of more air trapping in emphysema.
Correct. So what is the main difference in the breathing between emphysema and chronic bronchitis, and why does it happen? The reason is the emphysema patients, they have puff, puff, puff. This looks like a cartoon, but it may help you to remember the reason for that. Strong hypercarbic drive. So pink puffer struggles always. Whereas these patients become, they are in type 2 failure. They have less of response to the accumulated carbon dioxide. So they lost the hypercarbic drive. And that is the reason why they are not that much puffing like the pink puffers of emphysema. Okay, so chronic bronchitis patients have lost the hypercarbic drive, and this is the normal person who is happy. So you can see, remember this picture, which will tell you why these things happen in this. What are the important points to be elicited while taking history from a COPD patient? This question will help you to examine a patient. When a live patient is given, you must know how to take the history from this patient. Some of the exam goings also can answer the questions.
Sir, what symptoms they have? How long? Duration of symptoms, sir.
Okay. So first question you have to ask whether the patient has been a smoker or not. Okay. Number of pack years. So this is a very common question they will be asking, because we told you that smoking is the most important cause for development of COPD compared to the other two causes which we saw, like the pollution and genetic causes and the recurrent respiratory infections. They all come only secondary. So smoking is the most important cause. So on history of smoking, you should ask how many cigarettes he smokes. So the common question they ask you is, what is the pack years, number of pack years? So number of packs per day smoke into the number of years of smoking gives you the number of pack years. Then second point, you want to know what is the effort tolerance of the patient, how much he can walk, whether he can have the bare minimum of 4 minutes which is required for everyone to have a normal day-to-day activity. Then you must ask whether the patient had any exacerbations, whether any ICU admissions, or whether he needed any mechanical ventilation because of severe hypoxemia or hypercarbia in the earlier days. Whether he has any comorbidities like hypertension, diabetes, or ischemic heart disease, and whether at present whether the patient has any active infection, any fever, cough, sputum production, and what is the nutritional status, because patients with COPD, They lose their appetite over a period of time because of repeated recurrent respiratory infections and hypoxemia. So their intake goes on decreasing and they become nutritionally undernourished, and that leads to loss of immunity, and the whole process becomes a vicious cycle. So I have highlighted the first letters of all the 6 conditions. So if you add them all, what is the mnemonic you get?
Sneak in.
Okay. You can see a can. Okay. So remember this mnemonic and you ask all these 6 questions to the patient. In the exam, if you are given a live patient, ask these questions and note down the answers for that. What are the symptoms exhibited by COPD patients and what are the physical findings you will find in them? So after history taking, we are going to examine the patient, okay, or we are going to ask them for the symptoms that they feel. So what are the symptoms
Chronic cough.
Very good. So these are the symptoms: cough, initially intermittent, then persistent throughout the day, then sputum becomes tenacious and mucoid, it becomes purulent, then indicating infection, and progressively they have more and more of dyspnea. So CSD, central supply, sterile supply. So cough, sputum, dyspnea are the symptoms given to you by the patients. When you examine them, you find respiratory signs. The chest may become a barrel-shaped chest. They may have pursed lip breathing. Then there may be either rhonchi or wheeze may be present. And there may be cyanosis. There may be neck vein enlargement. There may be peripheral edema, liver enlargement, loss of muscle mass. So if you find the neck vein enlargement, peripheral edema, liver enlargement, what does it indicate? If you find
carpal nails.
They have gone in for right ventricular failure. Okay, so carpal nail leading to right ventricular failure produces the engorgement of the neck veins, peripheral edema, and liver enlargement. So, which areas of the lung are affected in COPD? We have already seen. So, major areas are large airways, small airways, lung parenchyma, pulmonary vasculature. It is the small airways and lung parenchyma. And later on, pulmonary vasculature also will be affected. Large airways are later on, at the very late stages only it will be affected. So in the initial stages, it will be medium and small airways and lung parenchyma. This will lead on to affect the pulmonary vasculature, producing pulmonary hypertension. This will later spread to the larger airways in a very chronic case. What are the features of pulmonary hypertension? So clinically, can you find out from the patient's history whether the patient has already, a COPD patient has already developed features of pulmonary hypertension or not?
No, sir.
Patient will have tachycardia, palpitation.
Tachycardia. More than that, when the pulmonary pressures are high, what will be the breathing like? It will be easy or difficult? Difficult. So dyspnea should be there. Okay, inability to take a deep breath. Then, if pulmonary hypertension comes in carpulmonale, you said. So carpulmonale, will the carbon dioxide level be high or low? Will the patient have a chronic CO2 retention, or they will have a normal
CO2 retention.
CO2 retention will be there. So CO2 retention, how will it affect the pH?
Acidosis.
Patient will have respiratory
He will have respiratory acidosis because of carbon dioxide retention. So then they may have syncope due to aggravated hypoxemia. Okay, and heart failure and hypoxemia also will be there. Okay, so if you Add the first letters, you get the mnemonic dash. So dyspnea, acidosis, syncope, heart failure, and hypoxemia are the features of pulmonary hypertension. What are the characteristics of sputum in COPD patients? Will it be watery or will it be mucoid? Or will
Sir, it will be
greenish,
mucoid, but during active infection, it will be purulent, sir.
purulent, and it will change color. So you must ask for the quantity of sputum per day to rule out bronchiectasis. What is the difference between bronchiectasis and COPD, chronic bronchitis and asthma? Both the patients bring out sputum, but who will bring out more?
Bronchiectasis, sir.
Bronchiectasis patients will bring out more sputum. Very good. And what is the other important characteristic feature of the sputum production in bronchiectasis?
Copious.
Yeah, copious, large amount, all the same. But
Yes.
another important description you should ask the patient. Supposing he says, when I lie down on the right side, I get more sputum. When I lie down on my left side, I don't get. What is that called? Postural increase in sputum quantity. Okay, supposing the right lower lobe and middle lobe are affected, and if the patient is lying on his left side, he will produce more because that right upper lobe and middle lobe and lower lobe will drain all the sputum collected there. Whereas when he lies on his right side, they will all be retained because the left side is not diseased. It will be normal. So the postural variation brings out more sputum. So patient tends to lie in the right side all the time to retain the secretion because the cough is so irritating and troublesome. So this postural drainage of more sputum is very, very pathognomonic of bronchiectasis. Okay, not only the quantity is more, but also it is variable in various postures, which is not there in chronic bronchitis or emphysema. Then second is the color of the sputum. When it is greenish, it may be pseudomonas. When it is blackish, it may be because of small bleeding which has got altered and become collected along with the sputum. And smell, lung abscess and empyema, which are all called pyemic diseases. They all have a very foul smelling sputum, and patient's breath itself is obnoxiously smelling. What is that condition called medically? When
Merciful.
It is called halitosis. Okay, when the patient's breath is smelling awfully bad, it is called halitosis. And what are the differences in the microscopic appearance between COPD and bronchial asthma sputum? Appearances in the sputum of the patient with the COPD and bronchial asthma, which is the main test by which we can distinguish between these two conditions. What cells you can find in the microscopic examination of the sputum in a bronchial asthmatic patient? What are the cells that you can normally see in a COPD patient? This is one of the methods to distinguish between these two conditions. So in COPD, you will have more neutrophils, you have CD8 lymphocytes and macrophages. Whereas eosinophils, which can be stained by Gram stain, is more pathognomonic of bronchial asthma. And they have CD4 lymphocytes and mast cells are there. So if you examine the sputum under microscope, you can distinguish between COPD and bronchial asthma by the presence of the different types of cells that are seen under microscopic vision. So what are the physical findings in COPD patients? Of course, we have seen that earlier. So general build to assess the nutrition, patient may be thin built in emphysema and thick built in chronic bronchitis. The chest may be barrel shaped. So and the breathing may be respiratory rate may be high in the emphysematous patient, and lip may have the pursing effect. And cyanosis, you may be asked to define, first of all, define cyanosis. How do you define cyanosis? What is the definition of cyanosis? This is a common question asked in the practical exam when you present a case. If the patient with chronic bronchitis shows evidence of cyanosis, this one question,
Bluish
basic question.
discoloration of the
Bluish discoloration of the
skin and the
Skin and the-
mucous membrane.
skin, mucous, nail bed, skin, mucous membrane, even conjunctiva at times. Okay. Then what is the reason for this? How does cyanosis happen? This is definition is it is appearing. The bluish discoloration appears in various parts of the body. What is the cause for this? Why should this bluish discoloration be seen?
Decreased oxygenation or perfusion.
Because of
What are the
CO2
types of
reduction,
hemoglobin?
power of hemoglobin.
What are the types? You have two types of hemoglobin: oxygenated hemoglobin and deoxygenated hemoglobin. Okay, oxygenated hemoglobin is one which has full oxygen attached to the. How many oxygen molecules one hemoglobin can carry?
4 oxygen.
4 oxygen.
Four oxygen molecules. Okay, and it goes and delivers it at the tissue level and comes back with how many molecules of oxygen will be attached to the hemoglobin when it comes back to the lung? Will it deliver all the 4, or will it deliver only part of it and come back? Seems to be a very, very basic question, isn't it?
Yes.
All of us know that it is having 4 molecules attached to that, but when it goes to the tissue level and they deliver it for the mitochondrial oxidative process, the venous blood contains 75% of oxygen. Okay, the arterial blood takes 100%, but it returns with 75%. Only 25% is utilized. Okay, so that is called the deoxygenated hemoglobin. So the deoxygenated hemoglobin, beyond what level it will exhibit the cyanosis? How many grams of deoxygenated
5
hemoglobin
grams.
should be? You should have a minimum of 5 grams. Okay. So in a very severely anemic patient who has only 4 grams of hemoglobin, will he ever exhibit cyanosis? It is very difficult to make out cyanosis in a very severely anemic patient because you require a minimum of 5 grams of deoxygenated blood hemoglobin. This is the answer. It's expected out of you. And the differentiation between central and peripheral cyanosis. How do you differentiate patient having a central cyanosis and a peripheral cyanosis? What are the conditions causing this different types of cyanosis? So supposing you are operating on a long case, say for liver resection or liver transplantation goes on for 8 hours, 10 hours, and the AC at the operating room is at 16 or 14, and patient is not properly covered, and warming devices are not properly applied, and his hands and feet are exposed. What will happen to the fingertips? Will you see cyanosis there?
Yes, sir.
Yes. Okay. So that is the peripheral cyanosis occurring in the extremities. Whereas central cyanosis occurs now peripheries as well as in the central portion like tongue, palate, all lips, all these areas also will be affected. And which conditions produce predominant central cyanosis?
Cyanotic heart.
Cyanotic heart disease, fantastic. So you get it in more of allostetrology. All of you would have seen at least one case in your training so far. So allostetrology and cyanotic heart diseases where there is a left to right to left shunt. So all these cases produce more of central cyanosis compared to peripheral cyanosis. So if the peripheral cyanosis occurring due to the spasm of the small capillaries at the periphery, how do you distinguish? And there is some amount of bluishness in the lips also. How to distinguish between central cyanosis and peripheral cyanosis? This is another common question they will be asking you. Can peripheral cyanosis be reversed?
Yes, sir.
How? It happens because the extremities become cold and the capillary is going to spasm. So how can you re-establish the circulation? One, by warming the extremities. If you cover the extremities and give some warmth by heating blankets, then the vasospasm will decrease and again circulation will start happening. Second thing, by giving additional inspired oxygen, by supplementary oxygen, the peripheral cyanosis will disappear. Whereas central cyanosis, which is because of the shunting of the deoxygenated venous blood into the arterial blood, will it improve? If you give 100% oxygen to tetralogy of Fallot patient, will the cyanosis improve?
No, sir.
No. So these are the two important differences to distinguish between central and peripheral cyanosis. Central cyanosis does not improve with warmth or extra oxygen or supplementary oxygen, whereas peripheral cyanosis will disappear with warmth and supplementary oxygen. Okay. And patients may have dyspnea in COPD and cor pulmonale. And if you palpate the abdomen, they may have a palpable liver if already developed, as I said, cor pulmonale and right heart failure. And you may see accessory muscles working in the neck and veins will become more prominent. So what changes occur when you say a person's chest has become a barrel shaped? What is the normal shape of the chest and what is the change that occurs in the barrel shape? In a normal person,
The diameter
anteroposterior diameter
increases in the COPD patients.
So normal patient, the this is the picture. If you see, this is the transverse diameter is little longer than the anteroposterior diameter in a normal chest patient. Whereas in a patient with barrel chest, the anteroposterior diameter exceeds or become almost equal to the transverse diameter, and that is why you get this barrel shape. So this is another common question they ask you: what is the reason for the change in the shape of the chest? And what are the investigations you have to do in a patient with COPD? When they come for surgery, what are the investigations you expect the patient to have had before coming for fitness?
Sir, in CBC, HB to look for polycythemia or anemia because of nutritional deficiency, sir.
Very good. Then
total count to look for any active infections, sir.
Infections, very good.
Then routine investigations, RFT, electrolytes.
Yes. So total count to find out any increase in the total count to infection, and differential count to see whether any neutrophil to find out whether it is a bacterial infection, and increase in eosinophil to see whether it is bronchial asthma, and then urea, creatinine, X-ray chest, emphysematous changes, consolidation, all these things may be present. And EKG, you may have features of right ventricular hypertrophy, right axis deviation, R1 in V1 and V2, and sometimes atrial fibrillation also can happen in COPD patients. And echo, you should see for the right ventricular dimensions and increase in pulmonary pressure, which are the late stage cardiac involvement that happens in chronic COPD patients. So here is a X-ray chest shown here. Can you identify what is the pathology in this?
Right middle.
This is to mimic an ASCII question.
Right middle lobe of
Middle lobe consolidation. Okay.
yes,
And what about this?
emphysema.
Bilateral emphysematous changes in the. So the features are reduction in vascular markings resulting in hyperlucent lungs. So, and most of the emphysematous patients will have the so-called tubular heart also. Okay, the heart will not have the normal long shape. So Bronchovascular markings are confined more towards the hilum. So peripheral bronchovascular markings are not there because the alveolar are too much stretched and more air is there. So they become hyperlucent. Now, this is the way you find out the right axis deviation. You have to look into, this is the normal axis. When both the lead one complexes are pointing upwards, it is called the normal axis, whereas in the right axis deviation, this lead one, it is the negative deflection and the AVF will be a positive deflection. So this combination indicates that this is the right axis deviation. And this is the way to find out the difference in the right and left axis, just for the sake of knowledge. So how are pulmonary function tests classified and what are the tests done in COPD patients? How do you first of all classify pulmonary function tests? In any COPD, you have to be thorough with your pulmonary function test knowledge, because it's a common question that will come both in OSCE as well as in practical exams.
Bedside test and
Lab test. That is the way to classify them by the practical method of doing it. But when assessing, you can classify them as static and dynamic lung function test. Okay, pulmonary function test can be static tests are mainly, what are the static tests? 4 volumes and 4 capacities. So how do you measure these volumes and capacities? Which instrument you will find out this? You will have to do a spirometry test to find out what are all the volumes that you can measure using a spirometer.
Except residual volume.
Very good. Except residual volume, you can find out what are the other 3 volumes.
Tidal volume and
Tidal volume.
Expiratory reserve volume and
volume and
inspiratory
expiratory
reserve
reserve.
volumes.
TV, IRV, ERV. Tidal volume, inspiratory reserve volume and expiratory reserve volume. And from that ERV, if you remove the T, it becomes RV, residual volume. So these are the 4 volumes: TV, IRV, ERV, RV. So out of these 4, you can measure the 3: tidal volume, inspiratory reserve volume, and expiratory reserve volume. But residual volume cannot be measured. How do you measure the capacities?
By adding 2 volumes.
So the volumes are actually measured, but capacities are derived from combination of these volumes. Okay, so capacities are not directly measured. That is the point that you have to keep in your mind. The capacities are nothing but derivations of addition of 1 or more volumes. That is the capacity. So static lung volumes are important for evaluation of obstructive as well as restrictive ventilatory defects, whereas dynamic lung volumes are mostly derived from vital capacity and they are essential for diagnosis of follow-up of obstructive lung disease. Okay, so this is the picture you will commonly see in all the books. So you have the tidal volume, then you can, after a normal breath, you can still make an effort and breathe some more. That is called inspiratory reserve volume. And after a normal expiration, you can still forcefully expire some more, and that is called the expiratory reserve volume. So if you add this inspiratory reserve volume and tidal volume, it becomes inspiratory capacity. That is, you are able to breathe normally some amount, and if you make some more effort, you can increase the intake of your air. That becomes inspiratory capacity. And if you add the expiratory reserve volume and residual volume, it becomes FRC, functional residual capacity. And if you add these 3, IRV, TV, ERV, it becomes vital capacity. And if you add all the 4, it becomes TLC or total lung capacity. So there are 4 capacities: inspiratory capacity, functional residual capacity, vital capacity, and TLC or total lung capacity. So don't make a mistake of saying inspiratory capacity and expiratory capacity. There is no expiratory capacity. There is only a inspiratory capacity, FRC, VC, and TLC. Okay, so please remember that. And FVC, that is forced vital capacity, forced expiratory volume in 1 second, are all dynamic measurements. So sometimes the examiners may be asking, what is the difference? How do you define a static and a dynamic lung function? What is the definition of a static pulmonary function test and the dynamic pulmonary or a lung function test? Anything dynamic means it is moving. So when there is an airflow in and out, what you measure is the dynamic lung. But static is supposed to be at a level when there is, after you finish, there is no further movement. At that level, when you measure, it is called the static lung function test. So at the ultimate end, there is zero flow. Whereas in dynamic, it is continuing to flow. You are forcefully breathing out. Here, you are doing it in a normal way. So the difference between this is the static means it is not moving. So no airflow at the end of the attempt is called static. Further airflow forced out during the test is called dynamic lung function test. So this is the spirogram which you will see in an obstructive airway disease. This is the normal. What is you see in the green is the normal. And what is this which is marked in blue, this rectangle? And you can see here the x-axis shows the time, y-axis shows the volume, and this blue line in the green curve, what does it indicate?
FEV1.
It is written 1 second here. So the forced expiratory volume in 1 second is marked here. Okay. Whereas in obstructive airway disease, the same thing. See how much it has reduced. So you can see almost 80% of the expired air is breathed out in the first 1 second in a normal patient, whereas hardly less than 70% or 60% is breathed out. So FEV1 is grossly reduced in obstructive airway disease. So that is the thing that you will see. They may sometimes give you a graph like this blocking this caption. So you must be able to identify this. And this is the picture which shows the restrictive pattern, where you see there is a and if you see in obstructive, another point is the total volume is ultimately reached. It is almost close to the normal. Whereas in a restrictive, the total lung capacity is grossly reduced. So you find that the total volume is much lower compared to the normal, but the FEV1 for that particular volume is normal. So even though this graph appears lesser, you can find that almost 70 to 80% of this volume will be exhaled in the first 1 second. So FEV1 to FEC ratio will be normal in restrictive disease, but the total lung capacity will be very much lower. That is the way you different when you are given a interpretation of pulmonary function test to differentiate between obstructive and restrictive. In obstructive, FEV1 is reduced, but TLC is not reduced. Whereas in restrictive, FEV1 to FEC ratio is normal, but TLC is grossly reduced. That is how you have to interpret the changes. Now, what is timed expired or expiratory spirogram? What values are measured by this? What we saw in the earlier picture is a gross spirometry tracing, which tells you about the volume expelled in a given first 1 second, mainly to find out the FEV1. But if you measure the volume exhaled throughout the expiratory phase, then it can be called as a timed expiratory or expired spirogram. Why that is done? This also can be an ASCII question. Okay. So this is how you have to have the timed spirograms, which is a measurement of dynamic lung volume. And in the timed expired spirogram, you measure FEF 25 to 75%. What is this? What is the importance of this? This is the normal graph. This is the one. You find the FEV1C and the FEC. But you also find this marking here in this.
It is also prolonged in COPD patients.
COPD patient. But what is the important? How do you describe that? You can, if you can read the small letter the screen, it is called forced expiratory flow during expiration of 25 to 75% of the forced vital capacity. Okay. So when you breathe out, you have to breathe out all your vital capacity. That is why it's called forced vital capacity. You make an effort, special effort to expel the air from your lungs. But the first 1 second itself, you will be expelling most of the air. But during the 25th to 75% of the forced vital capacity, you will, that is coming after the FEV1, that maneuver is done mainly by the lung itself. However much you try, your muscles and your effort, it cannot expel that air. So this is independent of your air, your effort. So that is the reason why, which will show the importance of the obstruction at the medium nerve. So this is the normal spirometry, and this is how the 25 to 75% is calculated. And first 1 second you find the initial thing flowing out, then the FEF 25 to 75, the significance and what is its other name. Earlier it was called reflects the small airway patency. So this is the importance of this 25 to 75. So it is more important in patients with bronchial asthma, where they have the bronchioles which have the smooth muscle which go into spasm. They will be not able to expel it properly, and you can find out the severity of the small airway patency by measuring the 25 to 75% in the spirogram. And this was earlier called maximum mid-expiratory flow. Okay, another name for this is maximum mid-expiratory flow. So that is the name given to this procedure. Now some spirogram tracings are shown here. So identify this. This is the normal one for your. Is this a normal one or abnormal one? The red line here shows the normal curve, and the white line shows the patient's curve.
Abnormal, sir.
Abnormal. So what type of abnormality is there?
So FEV1 by FVC is only 56% of expected one, so it is obstructive.
Obstructive lung disease. Excellent. So that is the answer for that. Now here there is no other plot, only one curve is there. Now read this. FEV1 is 4 liters, FEC is 5 liters, and the ratio is 0.8.
Normal, sir.
It's a normal spirometry. So here to find the FEV1 is 1.9, but FEC is only 2 liters, and the FEV1 to FEC is almost 0.95%.
Abnormal restrictive pattern, sir.
Restrictive
Total
pattern.
capacity.
Okay. Total lung capacity. The FEC, if you see here, normal is 5. Here it is almost 3.2. Here it is grossly low. 1.9 is the FEV1, but total FEC is totally only 2 liters. So this is a restrictive pattern, as I told earlier. So this sort of graphs also can be given in the exam. Now, some of the instruments which are used for measuring these things, I'm going to show the instruments and you should name the parts of the instruments. What is this instrument? When you read the chapter on pulmonary function test, this picture will be there in most of the books. You carefully see, you can see the various parts. Just tell me what instrument is this? What instrument by, even if you make a guesswork, you can say this. What is it used for? I can tell you this is a drum and this is a pointer and this is drawing the graph in the drum and this is the mouthpiece. So I have given you the clue. So can you identify?
Taffy.
Plethysmograph is for whole body. This is a spirogram, old spirometer, old type of spirometer where these are all the parts. See, this is the mouthpiece. So patient has to blow through this and then he will have to blow here. There's a floating drum which will replace the air will push the water. So it is suspended in a water and this will move. This is the counterbalancing weight. And this is a pointer which will record in the drum and give you the, so this is a very old type of spirometer. Nobody uses this nowadays, but exams for OSCE you have to know. So they may be asking you. So the parts are mouthpiece, then it goes into the floating drum which is suspended in a water bath and there is a balancing weight and there is a pointer writing on the recording drum. So these are all the parts of the whole type of spirometer. What volumes can be measured by spirometry and what volumes cannot be measured? Already we have seen that. So you can measure the tidal volume, you can measure the inspiratory reserve volume, you can measure the expiratory reserve volume. But residual volume cannot be measured. Okay, and you can also measure FEV1 and expiratory passes using this. Now, what are the bedside pulmonary function tests which you can do if you can't take the patient to the pulmonology lab or pulmonary function test lab? What are the bedside function tests you can do to distinguish between an obstructive airway disease and restrictive airway disease?
Match blowing test.
Very good.
The match
Cough
test.
Expiration time, subraceous breath holding test, Snyder match blowing, and D-Bono's whistle, Wright's respirometer use, and peak flow meter. Okay, so these are all the small tests that you can do post expiration time, that you can auscultate over the trachea, asking the patient to exhale as forcefully as possible and measure the time. If he exceeds 6 minutes, 6 seconds or more, it means what is the inference? Normally, a patient with a normal patent airway, how soon will be able to expel all the gases and complete the expiratory phase? What is the normal
3
expiration,
seconds.
inspiration time in a normal breathing? Say if you are breathing for 20 breaths per minute, what is the inspiration, expiration time?
Inspiration 1
Three-
second.
1:3.
2 seconds, sir.
1:2. See, total 60 seconds is 1 minute. So if you are taking 20 breaths, each breath is 3 seconds. So out of which 1 second is for inspiration and 2 seconds will be for expiration. Okay. So that is the normal. And even if you do forcefully, it should be completed within 3 to 4 seconds. But if it prolongs more than 6 seconds, it indicates there is some obstruction. Patient is taking longer time to exhale all the gases. So this is one of the very simple method of finding out the severity of an obstruction in COPD patient. Then subraceous breath holding test. What is the advantage of that? What is the other inference you get from doing this test apart from the and what
Takes an effort tolerance.
Cardiopulmonary reserve.
cardiopulmonary interaction. Very good. It indicates the cardiopulmonary indication. Why? How does it show the cardiopulmonary interaction or indication of cardiopulmonary reserve? When you ask the patient to hold the breath, what happens? Don't think of the Valsalva method. We are not trying to do Valsalva. What is the difference between Valsalva and breath holding test of subrachus?
That is against a
So
closed.
we have to ask the patient to
Ah,
close,
yeah, we are doing a forced expiration in a closed glottis. That is why we are purposely increasing the intrathoracic pressure. But when you hold the breath also, gradually your intrathoracic pressure will be increasing, isn't it? You are not exhaling. So after taking a deep inspiration, if you hold the breath, your lung is fully expanded and chest wall is also expanded, and so over a period of time you are going to have the slight increase in the intrathoracic pressure also will happen. But what are all the things that happen during subrachus breath holding test? How does the patient get oxygenated during the breath holding?
the effort.
FRC, functional residual capacity. So if the patient does not become deoxygenated during the breath holding, that means his FRC is very good. He has adequate amount of FRC to supply the oxygen during the period of breath holding. That is number one. And number two, because there is a slight increase in the intrathoracic pressure, venous return to some extent will be decreased, but cardiac output will be decreased, but heart rate will increase to compensate for that, and it indicates the adequate compensation by the heart also. But why you are not able to hold the breath as long as you like? After a few seconds, everybody has to release that holding and take an inspiration. What triggers the inspiration when you do the breath holding?
CO2 retention and stretchness of
CO2.
the.
Yes, very good. CO2 retention stimulates the respiratory center, which we saw in our basics of respiratory system. So that is the most powerful stimulus. So you cannot hold it. And the second reason is, what type of muscle is diaphragm? Again, we learned this in the basics class. Diaphragm is partly voluntary and partly involuntary. Okay, so you can hold the breath only if you are well trained athlete, you can hold for a longer time. But in a normal person, you cannot hold it for beyond certain limit for two reasons. Why? Because the diaphragm is partly voluntary and partly involuntary. Even if you don't want, you will be breathing. So if you are a sage who is practicing yoga, then you can hold for even 4 minutes, 5 minutes, but not the normal person. So the two reasons why you are not able to hold the breath beyond certain limit is, one is the powerful CO2 stimulation of the respiratory center. Second is the involuntary contracting nature of the diaphragm, which is only partly voluntary. So what is the normal value for breath holding test? Which will you
More than
accept as
45
the,
seconds, sir.
no, what is the most minimum a person should be able to hold?
20
Beyond which
seconds.
is
30 seconds, sir.
15 seconds. Lowest is 15 seconds. If a patient is able to hold the breath for 15 seconds, that means you can accept him for surgery. Okay? Less than that is a very high risk patient. Okay. Then Snyder match blowing test. How do you do the test?
The
Ask
patient
the
to
patient to blow a match held at what distance?
6 feet.
6 inches or 15 centimeters away from the open mouth. Person should not purse his mouth and blow. He should keep his lips up, well open. Okay, mouth should be fully open, and he should do an effort from the abdomen, like that. He should not do like that, pursing the lips. Okay, that is a very important method of doing it. And this is another deep nose whistle, which will also tell you about the peak expiratory flow, and right respirometer and peak flow meter. I don't know how many of you have seen these instruments. So these are the instruments that are shown here. What is this instrument? This is what I told you about. This is the right respirometer. Okay, some hospitals may still have this in the instrument trolley. So you may be asked in the practical exam when you go, they may ask you, have you ever seen this instrument? Luckily, sometimes it will be written here, right respirometer, it will be written. So always look for any writing in the dial to see whether you can identify the instrument. Now you have two markings in this, two dials here. What is the inner one? What is the outer one?
Outer is a peak expiratory flow.
Cannot measure peak expiratory flow in this. The inner dial is for measuring the tidal volume, and the outer dial is for measuring the forced vital capacity. Okay, this is called the right respirometer. The inner dial is divided into 100 ml, 0.1, 0.2. 1 liter is divided into 10. So each division is 100 ml. So normal tidal volume is about 450 to 500 tidal. So you have a pointer separately for that, and you ask the patient to breathe normally. Attach a face mask here. This is the lower end where you have to attach a face mask and keep it on the patient's face without any leak, and then ask him to breathe normally. Then this inner pointer will show. So you have to take a minimum of 3 readings and take the average of that or the best of that. So that is how you measure the tidal volume using the inner dial. And when you ask the patient to breathe out maximally after a maximal inspiration, this outer one will show the total volume that is exhaled. Okay, so that is the purpose of these two things. There are two buttons like things here. Can you tell me what is this for? Of course, most of you would not have seen, so I will not waste. One is for resetting these two pointers to 0 level. So if you press this, both the needles will come to 0. So you can start the measurement. Another one is you keep the face mask attached to the patient's face. This is the start stop button. Okay, so this is the reset button. This is the on off or a start stop button. So you have to press this button after explaining to the patient and keeping the mask on the patient's face. Then you say ready and then press this button, then it will start moving. And when you have completed 3 readings, you press this button, then the pointers will stop at wherever they have moved, so that you can read the readings. Okay, and always keep the dial facing you so that you can see the movement of the needles. And here it is easy, as I told you. What is it written here?
Right peak flow meter.
Right peak flow meter. So this is used for finding out the peak expiratory flow rate. What is the normal value for peak expiratory flow rate? The male and the female, is it same or different?
It is high for males.
450 to 600 liters per second. That is the speed with which the air goes out. It is not the volume, it is the speed. Like when you drive, you say, I am driving at 120 kilometers per hour. That means you are not traveling 120 kilometers. You are traveling at that speed. If you go in that speed, in 1 hour, you will reach 120 kilometers. Okay. So like that, it is the speed with which the air goes out. So 450 to 600 liters per second is the speed with which air goes out in a normal healthy lung, whereas it is 300 to 400 in a female. Okay, so that is the these are the two instruments, right peak flow meter, which may be sometimes kept in the examination for you to identify. Now, what is the test being done here?
body participant.
Huh? This is again what they are doing. Like you see, whenever a patient is asked to blow through something, the mouthpiece, and you can see their nostrils are pinched with a clip. This is the way a normal spirometry is done. So all the air comes out only through the mouth and nothing leaks out through the nose. So this is a very important step, and everything will be recorded here. And this is a spirometry done in the lab. Nowadays we want everything at the bedside. Okay, any test that we want, including ABG, we want to do it at the bedside. So this is a portable spirometer. Okay, what is shown here is a portable spirometer to do the PFT at the bedside. And this is the mouthpiece. This is the handle for the patient to hold it. And then he has to breathe through that. And you can easily see all the display that is coming here. And you can also have a printout of the same. Okay. Now what is shown here?
Flow volume curves.
Flow volume loops. It should not be called curve. If only one half of it present, then you can call it as a curve. For example, only if this portion is shown, you can call it as a flow volume curve. But when it is completed, both inspiration and expiration are joined together, it should be called as a flow volume loop. Okay. Okay. So can you identify these various shapes? There are totally 6 shapes given here.
First
So
one
can
is
you-
normal, sir.
First one is normal.
Second and third obstructive patterns, sir.
Very good. Excellent.
Fourth and fifth restrictive patterns, sir.
Fourth and fifth, sixth.
Both
Fourth and fifth.
obstructive and restrictive.
Fourth is obstructive and restrictive. So this is supposed to be restrictive because it is almost like a miniature of the total volume exhaled is not equal. So this is the restrictive pattern of a flow volume loop. But I'll show you what is the answer for the different flow volume loops. Identify the conditions. So this is normal, as you rightly said. This one is early small airway obstruction. As you rightly said, both can be classified as obstructive airway disease. But when it becomes too much scooped out, it becomes COPD. But if it is partly depressed like this, it can be called as early small airway obstruction. This is called fixed large airway obstruction. When it is larger on the top and smaller at the bottom, but there is no elongation, then it is called a fixed large airway obstruction. And this is called the variable extrathoracic large airway obstruction. So cases who have tracheal stenosis or bronchial tracheostomy narrowing, all those conditions will produce different types of obstruction. So there are 2 types of obstruction. One is fixed large airway, variable large airway obstruction. So these 2 are the patterns you will get in that. This is the restrictive type of disease. So this also can be kept in the OSCE for you to identify the various types. So how much more is FRC in erect posture compared to supine posture? Is there a difference, first of all, between erect and supine posture in FRC of all even normal patients? Yes. Why it is so?
So because of upward movement of the diaphragm.
Because of the intra. Correct. So that is the answer for that. So FRC is posture dependent. Increase by 30% in erect posture. Fine. Okay. What are the functions of FRC?
It acts as a O2 reserves.
Very good. Helps in oxygenation during expiratory phase. Very good. Then reduces work of breathing by keeping the alveoli partly open. Okay. Every time if the alveoli totally collapse and then they have to open, it will require more effort on the patient. So work of breathing is reduced by keeping the alveoli partly open, helps in mixing the fresh air with the residual air, okay, so that there is a uniform absorption of the gases. So what is the relationship between FRC and CC? What is CC?
Closing capacity.
Closing capacity. So what is the relationship between the two? Is there any
Normally,
relation?
Closing
FRC will be
capacity
more
is
than the
where the
closing
smaller
capacity.
airways tend to close.
CC is also age related, increases with age. That is, closing capacity increases with age. So FRC is equal to closing capacity at 66 years of age in the upright position and at 44 years in the supine posture. Okay, so as the person becomes aged person, then the closing capacity goes on increasing and almost becomes equal to FRC even in the erect posture, when it should be normally lesser than the FRC. Okay. What is equal pressure point and what is its importance? All these questions are mainly for ASCII training. Okay.
So it is the point where the lung collapses and the chest wall expands. Equilibrium point.
The equal pressure point states that expiratory flow limitation occurs at the precise location along the tracheobronchial tree where intraluminal and peribronchial pressures are equal. Okay, so if you see a picture of that, at equal pressure point, airways that are not supported by cartilage will collapse. This is the importance of that. So equal pressure point is where the intraluminal and peribronchial pressures are equal. And at what part of the tracheobronchial tree it happens is very, very important. In normal patient, where will it happen? Where will the intraluminal and peribronchial pressures become equal in a normal healthy patient's tracheobronchial tree? Will it become outside the thorax or inside the thorax? So if you see this picture, you can see this is the airway. Okay, here it is a cartilage supported airway. In both the pictures you can see, in a normal person, when you do a forced expiration, so equal pressure point becomes more important only when you do a forced expiration. In a normal person, you find this is the alveoli which has got the air, and as the air travels the airway, the pressure, which is plus 20 millimeters of mercury, gradually drops because it is going to a larger airway. And when it reaches 15 millimeters of mercury, it has come to a part of the tracheobronchial tree well supported by the cartilage. Okay, whereas in a patient, so what happens? Air is still able to go out. It is not, and ultimately when it reaches the mouth, it should equal the atmospheric pressure. So it will become equal to atmospheric pressure. And in a patient with COPD, because the dynamic obstruction is there in the lower airway itself, as the pressure, the alveoli air goes out within the thoracic cage itself, where there is not supported by any cartilage, the pressure drops to 15. So the obstruction becomes so much that patient has to put in more effort to breathe out this air or expel this air. So that is the mechanism why these COPD patients find it difficult to breathe out more than breathe in, because this collapse occurs inside the thoracic cage at a place where there is not supported by the cartilage. Okay, so that is the importance of equal pressure point. Mainly in COPD, this is the most important point which causes the dynamic obstruction in addition to the anatomical narrowing that happens. Now, what is shown here, can you interpret this? This is again another pyrometric and tracings, and you can read the small letters, you can identify what it is. You read what are all the values that are given here. You see this spirometry volumes are given FEC in liters, FE1 in liters, FEV1 and FEC, and predicted lower limit of normal, actual, predicted. So what is this totally?
It is less than predicted.
No, what is shown here? It is not a spirometer. It's a part of the dynamic test, FEC, FE1 and all, no? So pulmonary function test report. And why they have given two values and two color graphs? Answer is this. Okay. So this is a pre and post bronchodilator results. So this is a pulmonary function test done to assess the effect of bronchodilators. So the pre-bronchodilator values are this, and you ask the patient to inhale the bronchodilator and take this. So if such reports are shown in the OSCE, you have to say this is the red line is before bronchodilation, green line is after bronchodilation. I have purposely blocked the top portion so that for you to identify whether it is you are able to say. So if you see two values, always remember it is pre and pro bronchodilator. Okay. If a patient is not an asthmatic, then they will give only one value. So if the patient is a known asthmatic and it is using some bronchodilator, to see the effectiveness of the bronchodilator therapy, they always give two values. So if you find two values, you must know that it is pre and post dilatation. What is shown in this? This is again a picture of another test that is being done. Patient is inhaling 100% oxygen. There is a nitrogen meter. There is a pneumotachograph and transducer integrated. These are all the graphic representations that you get.
Measurement of anatomical dead space.
Fowler's method to measure the anatomical dead space. Very good. So how to calculate physiological dead space? You normally measure, you can measure the actual values of anatomical dead space. But what is physiological dead space?
Sir, it is usually zero because of minimal shunting.
Okay. How do you define physiological dead space? Anatomical dead space. What is the definition of anatomical dead space?
There
The
is
airway which
there is no ventilation.
the airway which doesn't take part in gaseous exchange.
The wall. You don't say airway, but you say volume of air that is present in the airway which does not take part in gaseous exchange. That is anatomical dead space. Like the air in the trachea, air in the major bronchi, air in the major lobar bronchi. All these things are not taking part. They are just inhaled and exhaled as it is. So the volume of air that is not taking part in gaseous exchange is called the anatomical dead space. But in physiological dead space, air goes up to the alveoli, but that alveoli is not perfused. It is not receiving the blood supply. So there is no gas exchange again. It is not able to take in the oxygen and exhale the carbon dioxide. So that's such alveoli which are ventilated but not perfused, they come under the category of physiological dead space. So how to calculate that?
By Bohr's equations.
Very good. Bohr equation for physiological dead space. This is the equation. Vd by Vt. That is dead space by tidal volume. Earlier it was, what is the difference here? The capital A is here, here small a is here.
One is alveolar.
Alveolar carbon dioxide. This is arterial carbon dioxide. Okay. So it is difficult again if you want to measure exactly the alveolar carbon dioxide, you have to go invasively and try to assess that. So as a surrogate marker for alveolar, you are taking arterial carbon dioxide level, which is easy to measure with an ABG apparatus, and exhaled carbon dioxide. So all of you should remember this formula, which is called the Bohr's equation. alveolar carbon dioxide or arterial carbon dioxide minus the end-tidal carbon dioxide divided by arterial carbon dioxide is the method of finding out the physiological dead space. What other tests are done to assess the pulmonary function? Apart from these pulmonary function tests, what are all the corroborative functions or tests that you should do? ABG, 6-minute walk test, pulse oximetry at rest and after walking, and cardiopulmonary exercise testing. All these things are corroborative testings. What is this shown here?
Cardiopulmonary exercise testing.
Cardiopulmonary exercise testing. Very good. What information can cardiopulmonary exercise testing give?
So the O2 consumption.
So it is an integrated measurement of both cardiac and pulmonary function. That's why it's called cardiopulmonary exercise testing. Okay, it provides assessment of exercise response involving the pulmonary, cardiovascular, as well as skeletal muscle system. What are the important values obtained from CPET?
So maximum heart rate and the maximum O2 consumption.
Very good. Anaerobic threshold. This is the terminology that all of you should remember. Anaerobic threshold. That is, what is the level beyond which tissue oxygenation will suffer and the aerobic respiration will go on to become anaerobic respiration. That is called anaerobic threshold. Peak oxygen consumption and ventilatory efficiency for carbon dioxide. What is 9-panel plot of CPET? This is a method of giving the report, just like the pulmonary function report which you saw earlier. This is the method of giving a CPET report. Okay, it looks like this. It will have a panel of 9. You can see panel 1, panel 2, panel 3, panel 4. So there will be 9 panels in this, and that will tell you about the 9-panel plots. The way CPT tells the results are given. Here panel are the numbered 1 from 9 from top left to bottom right, and the cardiovascular system is represented by panels 2, 3 and 5. You can see the more colorful ones, 2, 3 and 5, where you have multiple colors. They represent the cardiovascular system, and the ventilation is represented by panel 1, panel 4 and panel 7 in the same line. If you say all the 3, this is the ventilation, and panel 6, 8 and 9 represent the ventilation perfusion relationship. So this is given in the British Journal of Anesthesia. So I thought suddenly the examiners may introduce this into the ASCII. So you should be better aware of this. So because cardiopulmonary exercise testing is becoming one of the in thing in assessing the pulmonary and cardiac patients, and a lot of workshops are being conducted in various CVMs about the CPET. So it is better that you learn this and keep it in your mind. So this is called the 9-panel plot of CPET to give the results of the cardiac, pulmonary and the interrelationship between ventilation and perfusion. Okay, so these are the way it is presented. How is 6-minute walk done and how is it the result analyzed?
So in a closed room, the patient is asked to walk in the on his or her own same pace.
Very good. So patient has to walk on a flat surface. There should not be any ramp or any increase in height. It should be a level surface, normal pace. You don't ask him to run or do anything. Whatever his normal pace, he can walk. And median distance of 500 to 600 meters he should walk. And other parameters noted are SpO2, heart rate, and Borg scale for dyspnea and leg fatigue. These are the 4 parameters that are noted. And The results are analyzed like this. If the patient is not able to walk even 300 meters, he is a poor prognosis for aortic valve replacement. If he is able to walk 350, you have to consider what is LVRS for COPD. Lung volume reduction surgery, okay, especially for emphysema patients, they do this procedure to prolong the life of the patient. It's called lung volume reduction surgery. Less than 200 meters, high mortality for lung volume reduction surgery. Less than 400 with the heart failure, you must consider that patient for heart transplant. Okay, so these are all the inferences or analysis that is observed. Who developed this 6-minute walk test and what are its advantages? Okay, 6-minute walk test is a practical simple test, requires 100 feet hallway but no exercise equipment or advanced training. This test measures the distance the patient can quickly walk on a flat, hard surface in a period of 6 minutes. It was developed in 1963 by Balke to evaluate functional capacity in a person. It is easy to administer, better tolerated, and more reflective of activities of daily living than other walk tests. So you have 2 points. Starting point, the patient walks a distance of 600 feet, 100 meters, and then goes back like that. So the distance is 30 meters. Actually, the distance between the 2 points is 30 meters. So you start the stopwatch, ask the patient to walk, go around and then come back. So after 6 minutes, you find out how many times he has gone round to calculate the distance that he has gone. Okay, so this picture will help you. So it was developed by Balke in 1963. What is modified Borg scale which we use to assess how many rates are there? This also is given in this. So it is a rating between 0 to 10. And after 0 there is a 0.5. So patient not feeling dyspneic at all, you give a rating of 0. When the maximum dyspnea is there, you give a rating of 10, and in between you have gradually increasing severity of dyspnea. What is BORD index? It's an acronym. B stands for
Breathlessness, obesity.
No guessing. B stands for BMI. O stands for obstruction, which you can find out by FEV1. D stands for dyspnea, which can grade, and E stands for effort tolerance, so that is 6-minute walk distance. So what is BORD index used for? Right, it is used to assess the risk in COPD patients about his survival. It is not done for finding out whether he is a fit patient for surgery or not. Okay, BORD index is generally done by the pulmonologist to assess the longevity of the patient, whether he can survive, how long he can survive, what will be the quality of life. So if you see that there are 4 things: FEV1 predicted, distance walked in 6 minutes, dyspnea scale score, body mass index measurement. So you have points 0, 1, 2, 3, approximate 4-year survival interpretation. So values, if the patient has 0 to 2 points, he will survive for 80% of the patients will survive for more than 4 years. 3 to 4 points, 67%. 5 to 6 points, that is number of, if you get more marks, you are going to live less. That is the interpretation. So 7 to 10 points, 18% chance of 4-year survival. So the BORD index is mainly to assess the quality and longevity of the patient's life. It is not a matter of assessing the fitness for anesthesia. Please remember that. Now comes another thing, what is called GOLD criteria. What is this GOLD criteria? What is the expansion for GOLD? Okay, time is running out. So global initiative for chronic obstructive lung disease, but you are taking only G from here and then running to OLD. Okay, global obstructive lung disease. Initiative for chronic. Even if you don't remember global obstructive lung disease criteria. And what is it used for?
To see mild grade in
Spirometric,
COPDs.
It's a
FEV1.
classification of limitation of airflow in COPD. Okay, so you can find out mild, moderate, severe, and very severe stages. This is more important from your preoperative assessment part of it. Okay, so board index is not at all used as a measure of your finding out the fitness for anesthesia, rather than gold index is the more important investigation, or the index that the criteria will tell you about the severity, so that you can how is the COPD diagnosed using pulmonary function test. When you want to diagnose COPD, which pulmonary function test you will use? FEV1 to
FEV1
FVC
by
ratio.
FVC ratio.
So this is 0.7, less than 0.7, commonly considered diagnostic. So that is how this staging is done. If you see all these patients, they have less than 0.70 FEV1 FVC ratio. And finally, FEV1 predicted should be more than 80%, out of which it is less. Then as the rate goes up in severe, the predicted itself goes down, and the values are always same, less than 70%. So as the FEV1 prediction itself going down, you can see patient is in chronic respiratory failure. So 4 grades are there. So what is combined ABE approach to assess patients according to their level of symptoms in gold guidelines? Again, this is another method. Symptoms are assessed using modified British Medical Research Council scoring, or CAT scoring. There are 3 groups called the group A, which is a low risk group with one or no exacerbations in the COPD condition per year, not requiring hospitalization, and fewer symptoms with the dyspnea. Then the group B patients again are low risk patients. Again, number of exacerbations are very much less, but they have more symptoms of this MMRC, that is British Medical Council COPD assessment test. They have more than 2, or CAT test more than 10. And the last one is group E, which has a high risk, more than 2 exacerbations per year, and out of which 1 requiring hospitalization, and any level of symptoms of dyspnea. So this gold test is indirectly connected to these 3 groups to assess the severity, which is more useful from preoperative assessment point of view. What are the predictors of postoperative pulmonary complications in a patient with COPD? Can you classify them into some categories? Yes, you can classify them into patient related and surgery related. Okay, once the patient related, smoking is an important predictor of pulmonary complications. Comorbidities, if the patient belongs to ASA category 2, more than 2, age more than 70, and his albumin is less than 3, and BMI is more than 30, and effort tolerance is less than 4 meds, then all these factors pose a very important predictor of postoperative pulmonary complication. With regard to surgery, site of surgery, if it is especially upper abdominal surgery, which will cause splinting of the diaphragm in the postoperative period, general anesthesia, and duration of anesthesia and surgery more than 3 hours, all these things give rise to chances of pulmonary complications. How to optimize COPD patients before surgery? What are all the things that you should do?
For smoking
This is from
cessation.
the practical exam. Stop smoking first. Very good. So stop smoking. Right, then
Nebulization, deep breathing
incentive
exercise,
spirometry. Okay,
spirometry.
you have to assess improve the pulmonary function by incentive spirometry. Treatment of active infections using antibiotic. bronchodilators and steroids using nebulizer or inhaler, whatever it is. Okay, these are the 4 important steps in the optimization of COPD patient. What are the effects of chronic smoking on various systems in the body? This is another common question in the COPD case. So, what is the effect on CVS?
So it is a sympathetic
Carbon monoxide
increase.
causes increase in myocardial work. Okay, patients inhale carbon monoxide when they smoke. And catecholamine release causes coronary vasoconstriction, decreases exercise capacity. Respiratory system, we have usually decreased
Reactive
mucociliary activity,
airways,
makes the airway hyperreactive, and
increases
decreased pulmonary
secretion.
immune function. And also chronic cough, smoker's cough is another important thing which can give, especially after abdominal surgery, if they have consistent cough in the post-operative period, it may result in wound adhesions. And the long-term effects are interstitial lung disease and emphysema, lung fibrosis, COPD, all these things, lung cancer also can happen. With smoking causes testosterone imbalance in men and may be the cause for erectile dysfunction and muscle weakness. In women, it may cause hormonal changes interfering with proper reproductive functionality. And it reduces the incidence of, only advantage of smoking is they have less nausea and vomiting post-operatively. So how long one should abstain from smoking to revert the effects? All these questions are from practice, case presentation point of view.
At least 6 to 8 weeks.
6 weeks abstinence needed for return of immune function and to return of hepatic enzymes activity to normalcy. That is the reason why you need 6 weeks. This is the reason. But 6 hours of stopping will reduce the level of carbon monoxide by 50%, 12 hours by 75%, and with, if a person does not smoke for 24 hours, his carbon monoxide will be completely cleared. And what are the drugs used to treat tobacco addiction and how do they work?
Nicotine gums.
Nicotine gums.
Nicotine
patches.
replacement therapy. That is available as a nicotine chewing gum and or plasters, and spray gum lozenges are available. Then there is a drug called bupropion. It is originally approved as an antidepressant. It works by inhibiting the reuptake of norepinephrine and dopamine, just like a mood elevator, stimulating their release. There is another drug called varenicline, which has a nicotine craving by stimulating a receptor called alpha-4 beta-2 nicotinic receptor, but to lesser degree than nicotine. So instead of nicotine, this drug will stimulate that to reduce the craving for the taking the cigarettes. What are the goals and steps in the anesthetic management of a COPD patient? So if you get a COPD case, what are all your plans in the anesthetic management? So wherever possible, you should choose RA to GA. Okay. Pre-med, anxiolytics, anti-aspiration prophylaxis, continue routine medications except AC inhibitors, NPO according to the duration, the elective or emergency, bronchodilators by nebulization if needed. Monitors, routine plus ETCO2. Check the status of soda lime. Don't start a COPD case with an exhausted soda lime, which will add on to the problem of CO2 accumulation. Pre-oxygenation, caution in giving 100% oxygen, especially in chronic bronchitis patients who are in type 2 failure, where they are surviving mainly because of the CO2 stimulation. Not in a very severe cases, as I showed in the earlier cases in the slide. So too much of oxygen will make them less responsive to this. The breathing may sometimes stop totally. Induction agent of choice, propofol without metabisulfate. What is this metabisulfate used for in propofol? Any other drug which you use have this chemical in that? Metabisulfite? Okay, find out and tell me next class. Ketamine and xylacort are all the drugs that can be used. Relaxant of choice, vecuronium or cisatracurium. Atracurium can stimulate histamine release, so better avoid. Cisatracurium and rocuronium are safer. Intubation, wherever possible, you can use LMA to prevent the stimulation of the respiratory tract. ET intubation after sufficient suppression of reflexes is okay. Anesthetic management continuation, for maintenance you can use oxygen, air, CO or halothane. If the patient has a predominant wheezing tendency, the halothane, which is almost now become obsolete, is a very good drug to produce bronchodilation. And tidal volume should be only 6 to 8 ml, respiratory rate 6 to 10, and IE ratio 1:2 or 3. This is the setting that you should keep in the ventilator. Analgesic, you can use fentanyl, pethidine, dexmedetomidine or low dose ketamine. Reversal, you can use glyco or atropine to precede neostigmine and titrate it. So don't give the mixed ioperlate, try to use them separately so that you can reduce the amount of neostigmine. And management of intraoperative bronchospasm or tight bag. This is a very common question in the practical examination. So how do you answer this question?
You have keep 100% O2, deepen the plane of anesthesia, and you have to do bag and mask movies.
So first answer is always you identify the cause. Okay. So it may be machine cause or patient cause. So in the machine cause, it may be a activated emergency oxygen or a very high flow rate in the flow meter, or oxygen flush activated kinking of the tube or connector, malfunction of the valve. All these things are machine causes. Patient causes are endobronchial intubation, two-term plug or foreign body, bronchospasm, pneumothorax, aspiration, or pulmonary edema or embolism. So these are the first identify the cause. Then what is shown in this picture?
Shark fin appearance, capnography.
Excellent. Very good. Shark fin appearance capnogram to show the obstructed exhalation, asthma, COPD. How does this differ from the capnograph of obstruction in breathing circuit? Supposing you have an obstruction in a kink tube or a non-functioning valve, there is also obstruction. So how to differentiate between the obstruction due to bronchospasm or in the COPD and the machine? So if you find, this will be the picture. Okay. So here the downslope will be increasing more and more, and the trend will go down. So patients with airway or breathing circuit obstruction, it will not be a uniform shark fin like this. It will be initially prolonged expiration, but gradually it will become lower and lower. Here if you see, the CO2 level is going up, whereas here the CO2 level is coming down and the total respiratory effect itself is coming down. And here the trend will help you to find out whether it is a bronchospasm. Here it will be a uniform sort of shark fin trend, whereas here it will be going down the method. So how do you manage the intraoperative tight bag? So first identify the cause, then if it is a machine cause, what do you do? How to differentiate whether it is a machine cause or a patient cause? So for that, you must always do the disconnect from the machine and do ambu bag ventilation like this. And if you are able to ventilate, that means the machine is at fault. If you are not able to ventilate, it means the patient is at fault. So as simple as that. Disconnect the patient from the anesthesia machine, connect the ambu bag, press the ambu bag. If the chest is expanding nicely, that means machine is at fault. On the contrary, when you press the ambu bag and you are not able to squeeze the bag, then means patient is at fault. So patient causes treated according to the clinical condition. If it is aspiration, give 100% oxygen, clear the secretions by suction, steroids and antibiotics as soon as possible. If it is pneumothorax, drainage of air with a ICD. If it is pulmonary edema, IPPV with PEEP, diuretics, head up tips, 100% oxygen. If it is sputum plug, suction with saline instillation. Nowadays they don't recommend saline instillation. You can put simple distilled water and suction out. And bronchospasm, you can use the following drugs: salbutamol, aminophylline, magnesium sulfate, epinephrine, chlorpheniramine maleate, hydrocortisone, piperatoриum bromide, and ketamine. And the mnemonic for that is the same chick. Describe the flow chart to treat suspected bronchospasm during GA. So for those who have not had an experience on table, these are the steps that you have to follow. Management of a patient with suspected bronchospasm: switch to 100% oxygen, ventilate by hand, stop stimulation or surgery, consider allergy anaphylaxis, stop administration of any suspected drug. This is step number 1A. During that time, call for help. Difficulty in ventilation, there is a falling SpO2, then immediate management, prevent hypoxemia, reverse bronchoconstriction. You can deepen the plane of anesthesia. Ventilation through ET tube difficult or impossible. Check tube position and exclude blockade or misplaced tube. Necessary to eliminate breathing circuit occlusion by self-inflating bag. In non-intubated patients, exclude laryngospasm or consider aspiration. Drug therapy, you have to go the lower down, and secondary management comes later on, all these things. But the drug therapy, you can give metered doses of bronchodilator nebulized in 5 mg, or intravenous drug also can be given. Second line doses are piperatoриum, magnesium sulfate, hydrocortisone, ketamine, and in extreme patients, epinephrine, nebulized or intravenous. All these are the drug treatment that you have to follow. What questions you can expect in RS case are: anatomy of the tracheobronchial tree, physiology and control of respiration and non-respiratory functions of the lung, pharmacology of bronchodilators, mode of administration, pulmonary function test and ABG interpretation, physiotherapy and positive drainage secretions in various parts, smoking hazards and cardiopulmonary exercise testing. Types of cases that can be kept in practical exams: COPD patient for incidental surgery like hernia, orthopedic, lower limb or upper limb; COD patient for laparoscopic procedures or lung reduction surgery procedure or lung transplant; bronchial asthma patient for airway other incidental procedures; suppurative lung disease patients coming for empyema or drainage; cancer lung for lobectomy or pneumonectomy. And other basic things to learn: anatomy of tracheobronchial tree, anatomy of diaphragm, control of respiration, non-respiratory function, positions for lung drainage, alveolar and shunt equations, respiratory compliance and surface tension, high altitude physiology. So this is about the comorbidity of any questions on that? Exam going students, Dr. Rao, Ammu, Pavitra, are they all there?
No, sir.
Oh, right. So this is visible now. Is the screen visible?
Not yet, sir.
No, sir.
Not yet. Okay. Okay now.
Yes, sir.
Yes, sir.
Yes,
Okay.
Yes, sir.
Right. So the next topic, I'll rush through this. Half of it we have already learned, so it will not take much time. So I'll just try to complete that. Ischemic heart disease and anesthesia. I'm just giving a small case scenario. 68-year-old female complains of pain and swelling in the right ankle following a slip and fall at home 4 days ago. Inability to bear weight on the right leg. So this is the case. So what are all the points to be elicited in patients with ischemic heart disease? You have a patient who is given to you with a past history of ischemic heart disease for preoperative evaluation and management. If such case is given in exam, what are all the points in the history to be elicited? Past
when
history of
the first
hypertension, okay, detected when patient had persistent headache, then patient was prescribed. This is a treatment history, and she got regularly checked for her BP. How regular she was in attending. All that, and we saw in the hypertension management. Then history of chest pain and shortness of breath 4 years ago. Patient rushed to hospital. EKG showed inferior wall infarction. Emergency coronary angiogram done. All this is given in the history. You have to ask the patient all these things. So stenting of right coronary artery done with a drug-eluting stent. The patient also had 50% block in the mid-LAD. What are the leads of EKG showing the areas of infarction and vessels involved for diagnosis of MA? So this is the thing which you may have to remember in your examination. So if it is a anterior wall MI, you have to look in the V2, V4 chest leads. Septal V1 to V2, lateral wall lead 1, ABL V5, V6, inferior 2, 3 AVF, posterior wall V1 to V4. So the left vessels involved will be mainly left coronary main branch as well ascending as well LAD, anterior descending as well as circumflex. And the inferior and posterior wall, mainly the inferior is right coronary mostly, and posterior can be both left and right coronary. So these are the changes that you see. And this picture tells you how to identify the changes in the ECG in these leads. Now, post-stenting, patients start on ticagrelor 90 mg, aspirin, and atorvastatin, metoprolol. So, patient leads a normal life with good effort after stenting. So, now what is ticagrelor? These are some of the newer drugs which are used now routinely. So, what is the advantage and disadvantage of using this drug? Any idea? What is this ticagrelor?
it's an antiplatelet.
Antiplatelet, yes. Next generation to clopidogrel. Okay. So ticagrelor also known as AZ6140. That is the number given in the developing stage. The first reversibly binding oral direct acting P2Y12 receptor antagonist with a faster onset and a greater inhibiting effect on platelets, and are shown to be beneficial in patients with acute coronary syndrome. The adverse effects are excessive bleeding. You can have dyspnea, bradycardia, diarrhea, or sometimes ventricular tachycardia. Now, why ticagrelor is preferred over clopidogrel? Earlier, they were using only clopidogrel and aspirin, but now you see all the cardiologists, they are writing only ticagrelor. One reason is it's a very, very costly drug. Maybe the pharmacies are pushing the, pharmaceutical companies are pressing the cardiologists to use that, but yes. Though similar to clopidogrel, it also inhibits the ADP receptors. However, there's a binding site which is different. So inhibition is reversible. So whereas the clopidogrel reversal is it is irreversibly bound. So that is why you have to wait whenever a patient is on clopidogrel. You have to wait for 5 to 7 days before you take up the surgery. Whereas here it is irreversible. It does not require hepatic activation as compared to clopidogrel. It is a direct drug. What are the various antiplatelet drugs and their mechanism of action? That may be the question sometimes asked. So this is the platelet, how they are activated by so many things. One is there is the release of thromboxane. Then there is a PAR1, that is protease activated receptor 1 antagonist. Then there are PD, that is the phosphodiesterase inhibitor, like dipyridamole silastole. Then there is a GP2B3A receptors, and then this P2Y12 ADP receptor antagonist. So these are the commonly used GP2 to 2B3A. What is the disadvantage with this drug? Axicimab, tirofiban, and iptafibril, they are all mostly given by parenteral route. Okay, and whereas these things can be given by oral intake. So these are the four mechanisms or five mechanisms rather by which the platelet inhibition is done. Out of this, the ticagrelor is the common thing that is now being used. And when this is being done, the discussion may be directed towards hypertension and anesthesia if that is the cause for IHD, and acute coronary syndrome can be discussed. Anatomy and physiology of coronary circulation, which we have seen in the basics class of CVS. ISD patient on medical management when they come for non-cardiac surgery or CAPG. Diagnosis and management of intraoperative ischemia and infarction under GA are all the questions that can be asked. Hypertension and anesthesia, because we recently discussed that, I am not going to deal with that in detail. So what is the blood pressure reading to brand a patient as hypertensive according to Joint National Council on Hypertension? What is the minimum value?
More than 130/90. 138.
80. So what is white coat hypertension? That also we have discussed. What is the etiological classification of hypertension? What is the highest BP reading which can be accepted in emergency surgery?
So 180, 100.
100. Yeah, very good. 180, 100. What are the target organ defects of long-standing uncontrolled hypertension? All of us know. We have, and what is pulse pressure hypertension and its importance? This also we have discussed. Isolated systolic hypertension also we have discussed. Then what is alpine anesthesia? We discussed in the last class. That's about how the swings happen. And what is the current recommendation in the drug treatment? Just to recapitulate, can you tell me what is the recommendation of drug treatment? Below 55 and above 55. What is the drug recommendation? What is the drug of choice for patients below 55?
Below 55, it is AC inhibitors and
or ARB.
ARBs.
Above 55, calcium channel blockers. Lastly, only cardioselective beta blockers. Then how to control intraoperative hypertension? This is one question I think we'll have to discuss a little bit this stage. So how do you control intraoperative hypertension? Supposing you start a ischemic heart disease patient for major laparotomy, and intraoperatively the BP slowly starts going up. What will you do? Again, just like the intraoperative bronchospasm, you have to find out the cause, whether it is inadequate anesthesia, inadequate analgesia, or whether it is fluid overload, okay, or whether any compression like that. You find out and then try to, don't immediately jump to start giving NTG drip, okay. So identify the cause, see whether even if the soda lime is exhausted, it will cause hypercarbia and hypertension in laparoscopic procedures. So be careful about that, identify the cause and then try to treat it. So what is accelerated and malignant hypertension? We discussed. Which antihypertensive drugs need to be stopped before surgery? That also all of you know. Now a few questions on acute coronary syndrome. What is the spectrum of acute coronary syndrome? Because IHT cases, these are the questions commonly asked in the examination. What are the spectrum? What are all the what are all conditions are called acute coronary syndrome?
ST segment. ST segment elevation.
Unstable angina, non-ST segment elevation MI, and ST segment elevation MI. Okay, these three conditions: unstable angina, NST, non-ST elevation MI, and ST elevation MI or STEMI. Okay, so how to differentiate between unstable angina and ST elevation MI or ST elevation. Of course, ST elevation you will see in the EKG, but between non-ST elevation MI and unstable angina, what is how to differentiate?
So non-ST elevation, other ECG findings and troponin will be elevated.
Yeah, main thing is biomarkers, troponin. The distinguishing feature between unstable angina and NHTMI is the presence of elevated cardiobiomarkers such as troponin, which imply myocardial damage. Okay. What is the treatment regimen for different presentations of acute coronary syndrome? What will you do if the patient, there is no troponin elevation, no ECG change, but patient has classical angina, what will you do? If there is troponin elevation, but ECG changes are not remarkable, what will you do? If it is a frank ST elevation MI with the ECG change, what will you do? So these are all the answers. Initial treatment of all ACS include aspirin 300 milligram. Any patient, whether it is unstable or non-ST elevation, ST elevation, you give 300 milligrams of aspirin. You can give heparin bolus or intravenous heparin infusion if there are no other contraindications. Antiplatelet therapy with ticagrelor or clopidogrel is also recommended. And the American Heart Association recommends an emergent catheterization and percutaneous intervention for ST elevation MI with door to procedure start time fewer than 90 minutes. So if the patient arrives in the hospital and if it is less than 90 minutes and all the investigations done show that there is a confirmed ST elevation MI, the ideal treatment is go for immediate angioplasty or angiostenting. Okay. A thrombolytic therapy is recommended if there is no PCA available. So the first choice is only nowadays go for percutaneous intervention. So if when a patient is in a rural area and it is going to take a long time to shift him to do the intervention and all that, then you can go for thrombolytic therapy. And less than time is very important. And for non-STMA elevation and unstable angina, try to control the symptoms with the initial treatment of aspirin, heparin, and analgesics. If symptoms are controlled effectively, then a decision can be made for timing again they have to undergo definitely an angiogram and other evaluations have to be done based on the comorbidities. But if the patient continues to have anginal pain, then again in these patients also you have to go for angio and proceed. Okay, this is the treatment that you have to remember. How useful is EKG in ACS? The answer is common electrocardiographic abnormalities include T-wave tenting or inversion, ST segment elevation or depression, including J point elevation in multiple leads and pathologic Q waves. So these 4 changes you have to remember: T-wave tenting or inversion, ST segment elevation or depression, and pathological Q waves. So this is how the normal ECG of a PQRST complex looks like. This is the ST segment, which is isoelectric here. It may appear like this with a ST elevation MI, the ST segment goes up. And in a non-ST elevation MI, it may be rather depressed. Okay? And the T wave inversion also may be there in non-ST elevation MI. So if it is only elevated, then it is called the ST elevation myocardial infarction. So what is seen in this EKG? Can you identify the various things? It is given 1, 2, 3, 4, 5, 6.
Progressive increase development of Q wave.
Excellent. Okay. Changes
ST elevation.
evolving. This is called evolving MI. Okay. So from the normal, it is gradually the ST segment is going up and up, producing a curving of the ST segment, and then it ultimately becomes Q wave inversion with a long pathological Q wave. So this is a progressing MI. So if you take a series of serial ECGs, you will find this sort of changes. So nowadays people don't wait for such long to identify all that. The moment they say this, immediately you will be rushed into the cath lab and all the procedure will start. So how useful are cardiac biomarkers in acute coronary syndrome? So help biomarker troponin helps to differentiate unstable angina from NSTEM. But nowadays, what is called follow biomarker. So you have to do the repeating of the biomarker testing after 6 hours, because sometimes the initial test may show a normal result, but you wait for 6 hours and then do repeat it. Sometimes you may find that it gets elevated a little late. So just like a serial ECG in the olden days, nowadays they say serial biomarkers are indicated if the patient is clinically having symptoms of MI or ischemia. Even if the first test shows normal result, you have to repeat it and then confirm there is no elevation to rule out any ongoing ischemia. What are the guidelines for antiplatelet therapy with the patients with bare metal and drug-eluting stent? This is another question they may ask you in the exam. So what is the guideline that you have to follow? How long the patient should be on antiplatelet therapy before you can stop it in case he has to undergo an emergency surgery? How
For
long?
bacterial stent, it is at least 3 months. For drug-eluting, it is for 1 year.
1 year, very good. So antiplatelet therapy for minimum 3 months to 6 months for bare eluting and minimum 1 year for drug eluting. What is bridging therapy or bridge therapy?
We can bridge it with the fractionated heparin.
So bridging therapy is you have to stop sometimes the antiplatelet agents when the patient needs a surgery to avoid excessive intraoperative or postoperative bleeding. But at the same time, the stopping of the antiplatelet should not result in the stent occlusion or stent closure. So to avoid that, you have to select some drugs which will not cause excessive bleeding during surgery and at the same time prevent a clot stent thrombosis also. So that is what is called the bridge therapy. So bridging is done. This is the Sullivan's guideline given in 2021. So for bridging therapy, you have to use characters, withdrawal of dual antiplatelet, surgical risk. So you have to balance between these two. So surgical risk of bleeding and stent thrombosis. These two things have to be taken into consideration. So the current recommendation is there is another drug called Cangrelor, which is available as a parenteral drug, whereas ticagrelor is a oral drug. So you can use this, or you can go for the GP23 2B3 3A drugs if Cangrelor is not available, and then depending on the number of days, you can stop the clopidogrel or ticagrelor and then go for, especially after stenting is done, if it is within less than 3 months if the patient comes for a surgery. These are all the guidelines that we have to follow. So these drugs have a very short duration of action and you can titrate them so that you will not produce undue bleeding, and at the same time you can prevent the clot stent thrombosis also. In anatomy and physiology of coronary circulation, we just saw them in the recent classes. So describe the anatomy, arterial supply, venous drainage, factors governing coronary blood flow. This is another question that you can expect in the ischemic heart disease patient. And coronary perfusion pressure, what is coronary reserve, what is endocardial viability ratio, what is critical coronary stenosis, what is coronary steal, ECG correlation of location of block in the coronary vessels. All these questions you have to expect if you get a IHD patient. And what are the pre-op investigations to be done in IHD patients before surgery? So CBC, platelet, PTINR, because most of them will be all non-dual antiplatelet drugs, the urea creatinine, RPS electrolytes, EKG. You must compare the new ECG taken with the old ECG to find whether sometimes the P wave inversion gets fully reverted in the period of time when blood flow improves. So you must always compare the old ECGs, and you can do a resting as well as stress echo. If you have any doubt about the re-occlusion, you can do a stress echo to find whether it's interested. And nucleotide perfusion studies, in extreme cases, you may have to redo the coronary angiogram also to find out the block. And what is the treatment of acute ischemic heart disease? So that lifestyle modification like weight reduction, smoking cessation, alcohol abstinence, diet modification, and exercise. Drug therapy given is the beta-1 selective beta blocker, calcium channel blocker, nitrates, nicorandil, AC inhibitors or ARB, antiplatelet agents, and statins. So this picture tells you about management of ischemic heart state. So lifestyle modification, drugs acting on the heart, drugs acting on the vessels to dilate them, and angioplasty or statins to prevent the plaque, make the plaque stable, and lastly, coronary revascularization. Sometimes you may have to resort to coronary revascularization before a planned elective surgery if the block is very severe. And how is the risk stratification done in patients with IST? What are all the risk stratifying tools that are used? All of you will be knowing. In 77, Goldman Cardiac Risk Index was used, which is a multifactorial risk assessment and taking 9 facts into consideration, and a total of 53 points classified the patients into low, intermediate, high, and very high risk. So these are all the points that you have to take: history, physical examination, ECG changes, and other factors. And so based on that, you can classify the risk involved in that. But because this is too cumbersome to remember all the points and then make a assessment, now we have, after 22 years of the first Goldman index, Lee et al. Revised the original Goldman index to simple 6 variables. All of you should be well versed with that. So based on that, only 6 points with regard to ischemic heart disease, presence or type of surgery, congestive failure, cerebrovascular disease, or diabetic requiring insulin, or a serum creatinine more than 2. All of them you are given just 1 point. So you get a total of 6 only. So if the patient has got no risk involved, then it is called class 1. The risk is very, very low. But if there are more than 3 points, then the risk belongs to class 4, where the risk is almost 11%. Okay, so just to assess that, you can take precautionary measures. And when the patient with IST comes for a non-cardiac surgery, you get these points in the history: effort tolerance using Duke's Activity Status Index, medication history and compliance, any evidence of recent worsening like recurrent chest pain, shortness of breath. Pre-op investigations, it should include EKG, echo, lipid profile, RFT, CBC. Risk stratification using Lee's revised cardiac index score. Optimization for elective surgeries with a lifestyle modification, diet and drug therapy. Intraoperative, wherever possible, you can use a regional technique, especially for limb surgeries, you can use plexus blocks. If GA is required, the goals are preload, afterload, contractility, rate, rhythm, and ischemia prevention. These are the 6 things you have to keep in mind in these patients: preload, afterload, contractility, rate, rhythm, and ischemia prevention. Always go for multimodal analgesia, which can include some of the blocks or local anesthetic techniques. Post-op, watch out for ischemia or infarction during the first 72 hours post-operatively, especially early in the morning, because that is the time patients usually do not complain of pain because the analgesics are given to control the postoperative pain, so they don't usually complain of the anginal pain, and lot of fluid shifts happen. So that is the reason why the first 72 hours is very, very important. And oxygen supplementation is a must for 48 to 72 hours for all ischemic heart disease patients, and restart their medications that they were taking as early as possible. But patients with ischemic heart disease coming for CABG also can be asked in the examination. So all the steps of history taking and other things you should follow for non-cardiac surgery. Surgical plan, it can be off pump or on pump. Nowadays, mostly off pump surgeries are done, which is done for stable patients with good LV function. So high risk patients with poor LV function only are done under on pump procedure. And you must discuss about the differences in anesthetic management between these two surgeries. So post-op management, fast track anesthesia, where you can extubate within first 8 hours. Especially in off-pump procedures, they do it as early as possible. And for emergency CABG management or acute coronary cath lab management also, you should be quite aware of. And there are conditions called complex high-risk CABGs, which with patients with severe diabetes and cardiomyopathy, or patients with ESRD who are advised CABG first before renal transplant. They are also high-risk cases. Failed stent patients, they pose a bigger problem because already a stent has been done and the result will be quite bad. The surgical challenge will be more. And multiple graft patients are also complex high-risk patients. And patients with pacemaker or implanted cardiac devices, they also pose a bigger challenge. Okay. So that is a very rapid conclusion of ischemic heart disease and anesthesia. So with that, we will work this. And any questions or any doubts on this? All exam going students, they all do you think you are benefited by listening?
Yes, sir.
Yes, sir.
Right. So any doubts, Vidya or Soundarya? Any questions?
No, sir. No, sir.
All clear.
Yes, sir.
Okay.
Thank you,
Right.
sir.
So I'll
Thank you,
tell you
students.
about the next class.
Sir,
much
today's
will you
homework is about metabisulfate.
Yeah. Did anyone find out the answer? What is the role of metabisulfate, and in which other drug you use you have metabisulfate? You have to find out that answer also. Another common drug which we are using every day, that also has metabisulfate. Okay. Shall we say good night?
Yeah. Can we sign off, sir?
Yeah, please. Thank you.
Yes.
Thank you very
Thank you,
much, sir.
Thank you.
Thank you, dear
Thank
sir.
you, sir.
Thank you, sir.